Great. Thank you, Dr. Gleave. As mentioned, my name is Colin Davey. I'm one of the PGY3s, and I'm going to be chatting about urethral stricture disease today. So the objectives of my talk will be to review the epidemiology and incidence of urethral stricture disease, discuss the pathophysiology of stricture formation, and then review the current and emerging treatment options for urethral stricture disease. So the true incidence of urethral stricture disease worldwide remains largely unknown. This is largely due to differences in etiological factors, epidemiological variation across the globe, and scarcity of published epidemiology studies. However, urethral stricture is one of the oldest urological diseases with confirmed documentation over 4,000 years ago, with depictions of urethral dilation being performed. And this prevalence has continued to change over the course of history. So I wanted to touch on the incidence in US, Canada, and globally as a whole. The incidence of urethral stricture in the United States, again, has largely been unknown, but it is the one country that has the most data, given many public claims and Veterans Affairs data that is out there. And on the left, this was a large population-based study using 10 sets of public and private healthcare databases to examine urethral stricture disease rates. And on the left, you can see that over time, the stricture disease rate occurred at approximately an incidence of 0.6%. On this figure on the left, which is from Veterans Affairs Hospital Database, there is a sharp increase in stricture rate after the age of 55. And this increases every 10th decade at a pretty steady rate. So initially 0.6%, getting up to approximately incidence of 1.9% with an age greater than 85. On the bottom here, this is another study that was looking at the same data just over a longer period of time. And they actually found that the rate of stricture in the United States decreased from around 1.4% to 0.9%. The reason for this isn't quite known, but this is what the data showed. From a global perspective, the incidence is really not known due to the lack of data, but there was one review that estimated that about 10% of a urologist practice in India involves urethral stricture disease. And then multiple studies from sub-Saharan Africa have estimated that the prevalence of urethral stricture to be around 15%. As you can see here, Nigeria, around 14%, Cameroon, 11.3%, Southern Africa, including all countries in the southern region, around 15%. This is obviously not the true incidence as it was based on hospital presentation, but it does highlight the significance of the disease burden in some of these low developing countries, which is significantly different than a developed country such as the United States or Canada. On that note, I want to just focus and just mention briefly that there are studies focusing on the specific etiology of urethral stricture, but these are not that common. And I think it's important to highlight that the fact that urethral stricture really is one of the only urological diseases that has such a stark contrast with regards to the predominant etiology when comparing its cause in developed versus underdeveloped countries. And multiple reviews have demonstrated that the etiology in underdeveloped countries most commonly include are based from trauma, infection, or lichen sclerosis, which is reported as an inflammatory stricture. Whereas in the developed world, our number one causes are either idiopathic or iatrogenic due to instrumentation or other urological procedures. And on the right here, this just demonstrates the predominant etiology of urethral strictures in multiple sub-Saharan African countries between 2011 and 2019. As you can see here, number one cause either being urethritis or trauma. And it's important to note that within these underdeveloped countries, the rate of urethritis and infection has actually gone down over time, and this is thought to mostly be related to awareness and treatment of sexually transmitted infections as well as HIV. But on that note, with them going down there, in developed countries, there's a large shift towards more iatrogenic causes. And I want to dig into that a little bit further as well. So, with regards to the Canadian context in particular, there is very limited data looking at the incidence across Canada, and the majority of any data looking at urethral stricture disease in a Canadian lens comes from Dr. Rourke in Alberta, and there's very little data looking at the incidence, the patient presentation, the causes, and the reconstructive trends, whether that's in an urban setting, rural setting, or iatrogenic versus idiopathic. So this was a study published in 2022, which looked at all the urethroplasties done between 2003 and 2018, so 15-year period, and they were broken down into 5-year tertiles. Anatomic success was determined by being able to pass a 16 French scope at 16 months and then reevaluated at 18 months. Interestingly enough, 1,300 urethroplasties were performed over this time, and the number one cause was idiopathic, which remained consistent throughout the study at around 39%. But what was interesting is initially in that first 5 years, trauma had an initial presentation of around 30%, with a significant reduction to about 13.9% over this 15-year period. And as we can see here in this graph, there was a significant increase in the rate of radiation-induced, iatrogenic, and lichen sclerosis related strictures over the time period of the study. Another thing to note in this study as well is that in the top left here, you can see that over this 15-year period, there was an increase in the number of urethroplasties performed. Again, this may be related to what I'm talking about in a little bit, which will be the multiple guideline changes recommending urethroplasty as the gold standard. And then I'm just going to highlight the one on the bottom right here. So figure D shows that there was a significant decrease in the number of prior endoscopic treatments prior to urethroplasty, initially 3.4, 3.9 per year, but then in the last 5 years, only 2.5 per year prior to any urethroplasty performed, which again highlights some of the changes with regards to guideline recommendations. And in this study in particular, 89 patients had at least one failed endoscopic treatment prior to urethroplasty, and 18.9% actually had undergone a prior open reconstruction. So what is this telling us? Why are these rates going up with regards to iatrogenic causes in developed countries? And based on this data I've shown, and with regards to Canadian context and an American context, there has been a significant increase with regards to stricture related to instrumentation or other urological procedures. So again, this is another disease within urology that is unique in the sense that most of a large proportion of the problem is being caused by urologists or previous instrumentation, as well as this idiopathic source. So I want to look at why and some of the other procedures that have been done that are potentially causing these increased rates of urethral stricture. So this is a large systematic review from 2022, looking at the clinical relevance of urethral stricture. Given that the rate of many of these new surgical approaches is yet unknown, this study looked at 80 studies comparing enucleation, ablation, or resection with monopolar or bipolar TURP. So all studies that documented urethral stricture showed that the lowest rate of stricture was in the enucleation group, and this included either enucleation with thulium, holmium, diode, or mono or bipolar enucleation. And then the lowest rate was actually in the ablation groups, which included laser vaporization, PVP, and then the resection group was either monopolar TURP or bipolar TURP. And then there was a sub-analysis looking at urethral stricture rate after monopolar versus bipolar as well as a sub-analysis looking at the influence of surgical time, post-op catheterization, and sheath size as well. So when breaking it down further, when looking at enucleation versus TURP, there was 31 studies included, and the stricture rate was significantly lower between the enucleation group and TURP. And then in the sub-analysis, the stricture rate was higher after monopolar TURP compared to enucleation, but when looking at bipolar TURP versus enucleation, there was no significant difference. And then the risk of urethral stricture was lower in the enucleation group at 12 months, which was significant, but over time, between 13 and 36-month follow-up, there was no significant difference in any stricture rate. And then looking at ablation versus TURP, so this was 49 studies included, and there was no significant difference in the stricture rate between any ablation procedure and TURP. The sub-analysis favored ablation over monopolar TURP and bipolar, but there was no significant difference at any follow-up time period. When looking at the sub-analysis regarding surgical time, post-op catheterization, and sheath size, there was no significant difference with regards to this study, but there was a relationship between TURP and a larger sheath size of 26 French versus ablation, which often used a sheath size of 24 French. And then with regards to surgical time, there was a higher incidence of stricture with surgical time over 60 minutes, but again, nothing significantly different. And then with regards to catheter length, so in all these studies they looked at here, there was a shorter catheter time after ablation and enucleation versus TURP, but again, no significance was shown. So this is another recent study just published in 2024, actually, looking at the incidence and management of BPH surgery-related urethral strictures, especially now with the onset of all these new minimally invasive surgical options. People are wanting to look at which one is the best and which one potentially has the lowest rate of stricture disease. So this study looked at 274,000 patients, and overall, the rate of stricture was 3.97% within 12 months. The primary endpoint in this study was the incidence of urethral stricture after different BPH surgeries, and the secondary endpoint was to identify associated risk factors. This was from a data set of all payer national claims database in the United States. And you can see in table 1 here, the highest rate was in the TURP group, however, did not specify whether this was monopolar or bipolar. The lowest rates of stricture in this study was related to laparoscopic or robotic, as well as urethral lift, resume, or aqua ablation. Again, this is just a little more information from this study. It's a bit of a busy slide, but on the top here with table 2, we can see that overall, approximately 94% of these urethral strictures were managed with minimally invasive treatments, whether this be urethral dilation or DVIU. And only 4.5% ended up going towards urethroplasty. However, interestingly enough, it does not comment on this 94% treated with initial endoscopic management as to whether or not there was disease recurrence. And as I'll touch on in a bit, there presumably was, and maybe this will be a later analysis that they want to add in. They did a multivariable analysis as well that showed risk factors such as age, diabetes, and tobacco use were all significant for urethral stricture disease. So those were the few looking at benign prostate surgeries and urethral stricture rates. But I wanted to also look at prostate cancer treatment as well, especially with the onset of many new focal therapies and radiation becoming prominent as well. So this was so prostate cancer is one of the most commonly diagnosed cancers among men, and first line is either radiation or radical prostatectomy, with typical 5-year survival approaching 100%. So much attention has been directed at looking at these functional outcomes and the side effects associated with this. And one of these main functional outcomes and side effects that we look at is urethral stricture. And it will only become more prevalent over time with the increasing number of prostate cancer survivors post-treatment. So this is a recent study presented at CUAJ in 2024. It's still pending full publication, but it was looking at the estimating the incidence of urethral complications following prostate cancer treatment. And again, there's still quite a lot of limited literature regarding the long-term incidence of urethral complications following prostate treatment, but this was looking at everyone from 2002 to 2021 in the Alberta Cancer Registry, and it looked at it at over 47,000 people. Of this group, 6.6% developed a urethral complication. And in this study, urethral complication was defined as either stenosis, fistula, urethral or bladder neck procedure greater than 30 days after treatment. And historically, we often consider stricture actually related just to the anterior urethra, and most with regards to prostate cancer would be more classified as stenosis or happening in the posterior urethra. For all intents and purposes, these studies were essentially calling them the same thing. So as you can see here, the most significant rates of stricture complications or urethral complications were related to the groups that had either radiation therapy plus radical prostatectomy or radiation therapy plus cryotherapy showed the highest risk. And you can see in this curve here that the red bar is radical prostatectomy, and that reached a plateau at around 10 years. But there was a significant difference among these groups. And these results are in keeping with other larger trials in the United States. The large American CAPSER database, published in 2007, looked at also a large number of men with prostate cancer and urethral stricture disease, which found an incidence of around 5.2% overall, similar to this Canadian study, ranging from anywhere from 1.1% to 8.4%, depending on the cancer treatment modality. So again, functional outcomes are being looked at more and more over time, given the high survival rate. And this was a study on the left here by Muse et al. Conducted a retrospective cohort study of over 67,000 patients. Interestingly enough, in this retrospective study, 72% received radiation therapy, with only 24% receiving radical prostatectomy. This is different from the majority of the literature, which you often actually see the percentages flipped. Often more people getting radical prostatectomy versus radiation. So that was just an interesting note in this study. But the rate, so the rate of urethral stricture following radiation therapy was around 8.4%, whereas radical prostatectomy was 5.3%. And then as soon as you start combining these modalities, the rate increases significantly. With regards to even up towards 19% when radiation therapy with radical prostatectomy. And just here on the right side, despite being diagnosed more frequently in radiation therapy, this notes that the rates of treatment were actually higher following radical prostatectomy than radiation therapy in this cohort. And then on the right side, this is just a systematic review and meta-analysis, again, looking to determine the prevalence of urethral stricture post-radiation. And in this study, 25% of prostate cancer patients are choosing radiation as the primary treatment, which is more in keeping with regards to the literature that I saw out there. And then importantly to note here as well is the pooled data of all this had quite a lower rate of urethral stricture. It was only 2.4%, happening at a median follow-up time of 4 years. And the median time to stricture formation was 2.2 years, sorry. 11 studies within this trial reported the location of urethral stricture, and the majority of these being bulbar or bulbomembranous urethra, getting up towards 90 to 100% after brachytherapy were in the bulbomembranous region. I'm just going to quickly touch on stricture pathology as it is important for stricture formation. So I'm not going to spend too much time on this, but just a quick overview. So a quick refresher on some basic urethral anatomy. The anterior urethra is comprised of the meatus, the penile, and bulbous urethra, which is encased by the bulbospongiosus muscle. And then the posterior urethra is composed of the membranous, prostatic, and bladder neck, as you can see in this diagram. This is important as you move through the urethra. As you can see in the top here, the profile of the surrounding tissue drastically changes, and you can imagine how a stricture in the proximal bulb or the distal bulbar urethra may be amenable to DVIU or dilation, given how much more muscular bulbospongiosus muscle there is to work with. And then just below this, it's also important to touch on the cellular lining of the urethra and how it does transition. As you move from more proximal outwards, the lining of the bladder neck, prostatic urethra, and part of the membranous urethra is bladder urothelium or transitional urothelium. But then this transitions to stratified columnar and pseudostratified epithelium in the bulbous urethra, which continues through the penile urethra all the way to keratinized squamous epithelium in the glands. So there is a significant change throughout the urethra, which is important for stricture pathophysiology and formation in certain areas. So this is, again, a complicated slide, but I'm just going to highlight it briefly, the general pathophysiology of stricture formation, which is fundamentally characterized by fibrotic changes of the urethral epithelial tissue and the corpus spongiosum that in turn causes stenosis of the urethral lumen. In a typical urethral spongiosum tissue, it is 75% type 1 collagen and 25% type 3 collagen. However, once stricture forms, this totally flips, showing us that it's actually now 16% type 1 collagen fibers and 84% type 3 collagen fibers. So when you move from the left to the right up top here, this demonstrates a urethral epidermal injury on the left side. Platelets and erythrocytes secrete large amounts of cytokines and recruit macrophages. And then in the middle here, these macrophages secrete cytokines such as TGF, or tissue growth factor, which has been shown to be highly prevalent in stricture formation, which promotes massive proliferation of fibroblasts and collagen synthesis. And then on the right side here, under the repair action of fibroblasts, collagen is deposited, and this transition decreases the ratio from type 3 to type 1 fibers, resulting in impaired elasticity, poor compliance, and stricture formation. The bottom left is a convoluted slide with a lot going on, but the main thing I want to highlight here is that it's been reported in multiple studies that TGF, or transforming growth factor signaling pathway, which is activated by type 1 receptors, promotes inflammation and progression through multiple different pathways, as you can see here, whether it's the SMADS pathway, the ROA-A pathway, the AKT-mTOR pathway, or the WNT beta-catenin pathway. All these promote conversion of fibroblasts to myofibroblasts, which activate autophagy through epigenetic mechanisms to amplify the probiotic effects. And the reason this is important is that there has been a lot of data coming out trying to target some of these pathways in order to prevent urethral stricture formation. Just a brief touch on radiation-induced urethral stricture. So on the left here, again, this is kind of the common pathway of stricture pathology. So there's some stimulus, whether this be bacterial, chemical, physical, or radiation-induced. There's this squamous metaplasia then these fissures develop in the epithelium. With urination, extravasation occurs, and the urine gets into these fissures. And then fibrosis from this pathway we just talked about before develops in the corpus spongiosum. This fibrotic plaque coalesces, and then if it's circumferential, it causes a stricture. So with regards to radiation, there are acute changes, but these often don't result in any stricture formation, and it's more commonly the later changes that result in this increased epithelium permeability, increased TGF-beta and collagen deposition, and then significant vascular injury with reduction of these small blood vessels and capillaries. And when you look at it from a histological level, there is significantly less vascularity and higher collagen density. And oftentimes the most common location of stricture following external beam radiation and brachytherapy is the bulbomembranous urethra. And this is thought to be as a result of being under direct radiation exposure. Whereas conversely, anything post-prostatectomy who undergo either salvage or neoadjuvant radiation therapy will have a stricture most likely occurring at the vesico-urethral anastomosis. And the only factor to really show an increased risk of stricture formation is combined brachytherapy, combination of external beam radiation and brachytherapy, which suggests that the most important factor influencing stricture rate is actually the cumulative dose of radiation. So that's another factor that people are trying to look at is whether or not a higher dose or a radiation dose schedule change can result in a decreased risk of urethral stricture formation. So in the Canadian guidelines, the current management options include DVIU or urethral dilation, which has been widely adopted given its simplicity and technical ease. Despite known poor long-term success, especially in the context of recurrent strictures, patients are still most commonly managed endoscopically with either dilation or urethrotomy. And the other options include urethroplasty, perineal ureterostomy, or this new class of treatment, which is these drug-coated balloons, which I'll talk about in a few minutes. So our Canadian guidelines suggest that there's no evidence to suggest whether DVIU is superior to dilation. And the evidence out there shows that there is very modest success with DVIU with a stricture less than 1 centimeter in the bulbar urethra and either 2 or less prior dilations or incisions. And then this success significantly decreases if the stricture is longer than 2 centimeters in the bulbar urethra, any penile urethra stricture, any recurrent stricture, or anything more than 2 prior endoscopic attempts. The CUA guidelines recommend that the success rate of urethroplasty is approximately 84%, whereas that as transurethral treatments is around 47%. So the gold standard really after any dilation should be urethroplasty, whether this be with an anastomotic approach, which is complete surgical excision of the stricture and then urethral reanastomosis, or augmentation with tissue transfer to increase urethral caliber, most commonly used with buccal oral mucosal graft. And then if you're not a candidate for urethroplasty, then oftentimes it's self-catheterization after DVIU, or in some cases, perineal urethrostomy. So this has been widely talked about in the literature, yet we still routinely see in urological practice multiple attempts at DVIU. But as you can see from a number of studies, there is essentially 100% recurrence of urethral stricture after a second DVIU by at least 44 months. And a more recent study actually showed that the success rates of urethrotomy actually may be much worse than previously thought. So the Canadian guidelines suggest success of around 47%, but this study by Santucci showed that the success after first DVIU might only be 8%, with a median time to recurrence of 7 months. This is important because within urology, we follow guidelines so heavily, yet this is a guideline that has been proposed across countries' guidelines that state that after 2 DVIU, there is no benefit to success and the recurrence will be 100%, but it's still routinely done multiple times. So I think this is just important that patients actually need to be counseled, at least if you're attempting to do multiple DVIUs. The recommendations from the CUA recommend that endoscopic management as the initial treatment of a symptomatic undifferentiated stricture. However, this does not apply to strictures with either high rates of recurrence, such as failed hypospadias repair, penile urethra, lichen sclerosis related, trauma related, longer than 2 centimeters. If there's a fully obliterated lumen, radiation-induced, bladder neck contracture-induced, or vesicourethral anastomosis stenosis. If it does not meet any of these, then the recommendation is urethroplasty. And in our guidelines, it recommends urethroplasty after 1 prior endoscopic attempt that fails. So our guidelines were made before this large trial came out called the OPEN trial. So the OPEN trial was a large multi-center RCT that looked at randomizing open urethroplasty versus endoscopic urethrotomy. They looked at the primary endpoint, which was patient-reported outcomes and avoiding symptom score, and there was no statistically significant difference with regards to urethral stricture patient-reported outcomes between the 2 groups over the 24-month study period. However, the secondary endpoints did demonstrate that there was a 48% reduction risk in reintervention with urethroplasty compared to urethrotomy. And I think, interestingly, to note in this trial is that they included intermittent self-catheterization after DVIU, but it was not considered an additional treatment, and it was not considered a stricture recurrence. So I think this is actually even more skewed. And with regards to the secondary endpoint, clearly, if you're considering this as a treatment failure, then the reduced risk of reintervention is much higher with urethroplasty compared to urethrotomy. This is just a comparative review of all the international guidelines, which are all trending to a move towards urethroplasty as the gold standard after an initial failed attempt at endoscopic management. And with regards to the AUA, they actually provided a 2023 update, which included the use of these drug-coated balloons with any bulbar urethral stricture less than 3 centimeters. And then they also recommended that urethroplasty be the initial option at diagnosis for any penile stricture or any bulbar urethral stricture over 2 centimeters. I found this is from the Japanese 2004 urethral stricture guidelines, and I think it's just a nice standardized approach to urethral stricture management, which is includes all of our Canadian guidelines in a nice flow chart. So essentially, we can attempt endoscopic management once if it meets these criteria, but if not, the gold standard should be direct to urethroplasty. I think with regards to all these guideline updates that have happened over the last 5 to 6 years, there has been a large rapid evolution in the management of urethral strictures. So from an era of dilation, we have moved to a more common approach of urethral reconstruction, given the increased ease of buccal grafts, the solid outcomes that have been reported, as well as the updated guidelines outlining urethroplasty as the standard of care. So this large-scale study highlights this change over time. There was no change in prevalence of urethral stricture disease over this 9-year study period, but as you can see in figure 1 here on the top right, urethroplasty performed per stricture diagnosis increased by 43% over this study. And then in figure 2, the ratio of recommended care to repeat endoscopic care increased by 87% during this study. And they described recommended care as treatment with either urethroplasty or endoscopic treatment within 6 months of diagnosis, and then treatment of any subsequent recurrence following a single endoscopic treatment by urethroplasty. So as you can see, with these guideline trends, there has been a push towards urethroplasty as the gold standard. However, urethroplasty is still invasive, it still has complications, and it does require a specialized surgeon. So as a result, there's been a growing interest in using adjunctive therapies at the time of DVIU so you can remain minimally invasive. Some of these targeting the specific pathophysiology characteristics of urethral stricture disease. So I'm going to briefly touch on the new kids on the block, most notably the drug-coated balloon, which has gained the most interest and has the most positive data suggesting its success. And again, just given the fact the recurrence rate is so high with endoscopic treatment, there's been such a focus on pharmacotherapy administered through endoscopic means, targeting either tissue fibrosis or stricture formation. So drug-coated balloons have become the mainstay, but these aren't the only things that have been looked at. As mentioned with regards to all those pathways in stricture formation, there's been multiple modalities that have been used as adjunctive therapies. So two that I will just touch on quickly are mitomycin C and triamcinolone acetate, or TAC. And mitomycin C is a anti-neoplastic antibiotic, which acts as an antimitotic and functions as an alkylating agent to inhibit DNA synthesis. This reduces fibroblast proliferation, type 1 collagen deposition, inhibits mitosis, and inhibits DNA replication. There is good evidence to show that mitomycin C submucosal injection decreases stricture formation. There is good evidence to show that. However, there's also has been significant reported adverse events. So as a result, this is no longer being studied or used, given the fact that it's hard to standardize a submucosal injection. And then some of the significant side effects included osteomyelitis of the pubis, tissue necrosis, or urethral fistulization. With regards to triamcinolone acetate, this is an intralesional glucocorticoid, and it's often been used in keloid scarring. It reduces inflammation through inhibition of leukocytes and monocyte migration. And there's no, with regards to this product being used, there's no statistically significant difference were found between the recurrence rates, adverse events, or success rates. But there was a significant difference in the time to recurrence. So with using this recurrence up to 10 months versus 5 months without, this highlights that, this may be a preventative approach, but it will not be curative, and the stricture will occur at some point. So the newest data looks at drug-coated balloons with paclitaxel. So paclitaxel is a microtubule stabilizing agent, long used as an effective chemotherapeutic, and it's a mitotic inhibitor which prevents cell division and proliferation, and its actions are known to decrease fibrotic scarring that leads to stricture formation. It's hydrophobic, so it aids in intraurethral absorption, and it's lipophilic, which increases tissue binding. And it inhibits this TGF-beta, which, as we mentioned earlier, plays a significant role in profibrotic growth factor during wound healing. So the most successful data has been this robust series, which recently the 5-year data from the initial robust 1 study has been published. They published yearly data for the last 5 years, and now the trial is closed after the 5-year data has been published. The initial one was a single arm trial. These are some of the inclusion factors, but I'll just highlight the results. So in this study, there was 53 men enrolled. Mean age was 50 years old, and the mean number of prior endoscopic treatments was 1.7. And as you can see here, there was a success rate of 58%. 14 exited early due to treatment failure, and then 14 didn't have a increased by 50% IPSS improvement. 29 of the 53 completed the 5-year follow-up. But there was a significant improvement in IPSS scores from baseline as well as Qmax. This was correlated to the diameter of the drug-coated balloon used. So in this study, they had some using a 24 French and some using a 30 French. Overall, functional success was 38% in the 24 French group and 77% in the 30 French group. Freedom from repeat intervention at 5 years was 71%, and most failures within the first 12 months. So the next study was the RCT, which was performed at 22 sites. And it looked at, it was randomized 2-to-1, so two either to DCB to 1 with a standard of care with DVIU. And anatomical success was described as the urethral lumen of 14 French or greater by cystoscopy at 6 months. So the results of this study, in total, 48 were in the dilation group, and 79% were in the drug-coated balloon group. The average age was 58 years old, with an average of 3.2 prior endoscopic treatments prior to the initiation of the drug-coated balloon, and the average stricture length was 1.63 centimeters. As you can see here, the freedom from repeat intervention was 77% at 2 years compared to 23% to control at 1 year. So this does show quite significant evidence in the favor of this drug-coated balloon. Interestingly to note, on the bottom left here is the majority were bulbar strictures, 71%, but there were a few penile strictures, and as you can see here, the ones that had penile urethral stricture, the freedom from repeat intervention was actually only 46%, which was significantly lower than the 82% found in the bulbar urethral stricture. So what is the impact of this robust series, and how is this going to potentially shape guidelines? I think, it does hold significant promise as a significant alternative to men who have undergone DVIU or prefer to avoid or delay urethroplasty. But I think there is some key questions that still need to be addressed. One of these being, what is the economic evaluation? There needs to be further studies looking at how this benefits compared to DVIU versus urethroplasty, as well as there's been some questions as to whether or not, if this will take over care, then how does this shape urethroplasty training from a trainee perspective? And then what is the role of these drug-coated balloons for penile urethral stricture? As you can see in the small sample size, it's significantly less effective than in bulbar urethra, but there's been no significant evidence for this other than that. And then what about the role of this for first-time strictures, as most of these people have had multiple endoscopic treatments before getting this drug-coated balloon? And then the last main question that I think will be interesting to see over time is the impact on urethroplasty following drug-coated balloon treatment. So I think that data is still not quite out there with regards to how effective urethroplasty can be following administration of this paclitaxel drug-coated balloon. I have a few more slides here, but I'm just gonna rip through them pretty quick with regards to where the future directions are going. This is just an interesting study that, again, was published recently in 2024. Basically, the main point here is that we have all these different stricture etiologies, but they don't factor into the treatment decisions. And if you look, at our uro-oncology colleagues, there's been a huge advancement in multimodal tailored therapy to disease pathophysiology, genomic factors, etc. So this study was trying to hypothesize that phenotypic signatures would emerge that would provide insight into the potential causative mechanisms and ultimately treatment targets for specific stricture subtypes. So they looked at inflammation, which was significantly different amongst cohorts. And interestingly enough, there was significantly more inflammation in these idiopathic strictures compared to a trauma-related stricture. And then there's a variety of cytokines that were significantly higher in different stricture pathologies, including the inflammation group. So it's one study, but it notes that these idiopathic strictures appear to have a more distinct pathophysiology from traumatic strictures, for example, and there is a higher rate of inflammation that is more seen with regards to lichen sclerosis, for example. So again, just moving forward, looking at therapeutics to target these specific inflammatory factors will be interesting to see. And then another novel concept that has gained traction over the last 10 years. So initially studied an animal model, was using liquid buccal mucosal graft from a rabbit model, and then injecting it via DVIU to see if it could help with wound healing and stricture reduction. So this has transitioned over the last 10 years from an animal model to, they did a small pilot study looking at six individuals, and then most recently they just submitted an abstract. The full manuscript isn't out, but it was basically looking at using liquid buccal mucosal graft on humans, and there was only 9 people in this study, but there was no adverse outcomes, and there was significant improvement in Qmax, IPSS, PVR, with a functional success rate of 67%. So interesting concept that I think will continue to gain traction as a minimally invasive option. And then again, just another area that's been going is initially in 2016, a group in Germany looked at engineering an autologous tissue engineered graft called Mucocell, and this initial study showed good success in 99 patients, and then most recently this was just published recently in 2023, which compared this autologous tissue engineered graft versus native oral mucosal graft, and the time to recurrence did not differ significantly. And with regards to the tissue engineered graft and oral mucosal graft, they had comparable success rates of 68 and 78%. So again, another interesting area in tissue engineering that I think will only continue to take off over the next 10, 15 years. So in conclusion, incidence in etiology of urethral stricture differs significantly when comparing developed and underdeveloped countries. Again, this is unique to urological conditions. And then again, the increased incidence of iatrogenic causes of urethral stricture in North America are most related to either idiopathic or iatrogenic. So that's instrumentation. And with the onset of a number of new BPH, minimally invasive surgical techniques, and focal therapy for prostate cancer, it'll be interesting to see how these rates increase or decrease over time. And then I think one important thing to highlight is just the gold standard of urethroplasty after one failed DVIU attempt. And I think this is still not being practiced. And I think there's a lot of room to grow with regards to following the guidelines that are showing such great success with urethroplasty. And then these drug-coated balloons do hold promise as a significant alternative, although I think this data may look good, but it's totally funded by the pharmaceutical company. And I think looking at the real-world data or discussing with practitioners in the field that are actually using it, it's discussing whether or not are these outcomes as good as the literature is showing. And I don't think that's necessarily true. Last thing, the future of urethral stricture management will likely involve these targeted therapies as well as tissue engineering and these potential liquid buccal mucosal graft, which is an interesting area that'll be interesting to see where this goes. So I need to give a big thank you to Dr. Kavanagh, who helped a lot, and then also Dr. Rappaport, who I chatted with a few times, who actually has used OptiLume. Yeah, thanks everyone for listening, and sorry I ran over time a little bit, but let me know if any questions.